Thank you very much for those talks. My question is to all three members of the panel. When we're setting up our neonatal units in low-resource settings, is there any role for the incubator, the hot room, or the separate intensive care room?
I start with Nils, and then I pass on to Mats.
Okay. Yes, there is. But 4 buts, 5 buts. I think with HIV, you were part of developing what the AFAS principles were. You remember those? Mm-hmm. And if you have certain conditions that you have the capacity to make those incubators safe, then I would say possibly. Unless you can fulfill a certain number of conditions, no. That would be my short answer.
Thank you very much. We'll come back to the levels of care and the preconditions at what you do what, when you do what. Mats?
I absolutely agree with Nils that there is still room for incubators also in low resource settings, but we need to use them carefully. We need to know what Nils has been saying, that the natural place is skin to skin with the parent, the mother or the partner, or someone else of the choice of the parents, and they should have access. That's the most important part. There should be space and the opportunity for the parents to be around with their baby 24/7. That's absolutely necessary.
And as you said, you wanted all three opinions. I don't think there's a blanket answer, because if we talk about a place where a lot of MSF projects are, and I think the first point is to establish good nursing care, to establish the proximity between the mother or the carer and the baby, and first and foremost, do no harm. And I think that by providing incubators in settings where there is no guarantee that we can really take care of the babies correctly in those incubators, I think we are risking of doing a lot more harm than good, and also isolating the babies from the mothers. That's not an answer maybe, but it's my opinion.
I just have another comment as well. I think there was a study from Uppsala, where Ove Ewald comes from, where they clearly show that the problem is not the incubator, it's actually when the baby comes out of the incubator. It's more the time spent with the mother or the partner decreased dramatically the moment you took them out of the incubator, put them in a heated bed or in a normal bed, because then the parents didn't want to disturb the baby. Mothers know that the baby in the incubator is isolated, and if they are given the opportunity to have them skin to skin, they take it.
For me, the question would go even further, whether we need cots for babies, but that we can discuss at a different point. There's another question up here.
Maybe it's just a remark. We are pediatricians, this is great. But what I was lacking a little bit, I was looking for the midwives and the obstetricians. They were not mentioned at all, and I think we should have a very close collaboration with them. Thank you.
Thank you. I'm not sure that there's anyone who would disagree, and I absolutely, I think we cannot do anything in terms of newborn care that doesn't go hand in hand with nurses, midwives, pediatricians, obstetricians, and not just pediatricians, just any health personnel who is working with us and the mothers. Mercedes.
Yeah, it's not really a question. It's taking the opportunity to really welcome the remarks you did about cultural sensitivity and the way it's been mentioned in other presentations. I would really like to emphasize very much how, I mean, this cultural issue is just universal, and it is just person-based, and I believe that we really have to understand what's going on and see what are the challenges to overcome, looking into the specificities of what's going on around our patients. That's just to recognize that, to acknowledge it, and to really greet it.
Thank you. There's another question over here, and then there's Tamam up there.
Hi, I'm Zolvi from Germany, and I was just wondering that one of the biggest practical questions often is how can we give the mothers or the family the time to actually stay with their babies, because they need to care for 6 more children at home, and making them stay with the baby in the hospital means these children will not be able to go to school, they will not be fed, they will be not looked after properly. And that's something I found very difficult, to make the mother decide between the newborn and her other children. Thank you.
I think that's for you, Nils.
Indeed. And I think the reality is, nevertheless, that child will come home and be cared for by somebody. That somebody may very well not, or even unlikely not, be the mother. Actually, in Africa, it will be the mother. She's the default. But she has twins. There was a beautiful picture we saw this morning of twins and a 6-month-old. And so, practically, those kind of situations when we have a system in place that makes allowance and welcomes access happens 1 in 20, 1 in 40. The other 39 find a solution. It can be grandmother, it can be somebody else, it can be a sister. Once I've had another elderly, 15-year-old sister come in, and that was a bit uncomfortable because I was okay with her, but my nurses were not. And so, yes, hard cases shouldn't make bad law. Yeah, there will be some cases that are very difficult. In Cape Town, we have a huge problem with TIC, with substance abuse. And I fail at times to find somebody to do skin-to-skin for those mothers. They're coming off the street. They don't have anybody on the street. Yes, there's a reality. There is a place for the incubator in the real world in which we come from.
Tamam, and then up there, sorry, I can't see you, but I can see the hand.
I'd like to just attach 2 of the remarks to cases I've seen in the field recently. One is about the incubators. And the incubators is I can hardly think of a place where that is usable, because the last time I've seen them used was in Yemen, where the expertise of using them was available and the disruptions. People knew how to use them when everything was okay. When you are in a conflict setting, electricity goes off and on, lights go off and on, and people are not available all the time. So I'm just saying that categorization of this is usable in middle-income countries and that is usable in low-income countries is a bit risky. And we face a more difficult task potentially in a place like Yemen, where they are available to advocate for skin care because people are not used to it. And this is another layer of touching on because we could be seen as advocating for facile or ineffective methods when they might actually save lives. The other one is on the idea of care. If we are serious about access, we wouldn't be discouraged by the fact that the mother is available or not available. We would find a solution for it, because our job is not only to provide access to those who are privileged enough to come to us and be there. So recently in Niger, I've seen mothers, grandmothers, aunts, relatives come, and they have to stay in a malnutrition clinic with babies up to 2 or 3 weeks sometimes, and we have to worry about how they are caring for other kids. But the last point is, I fear that we aren't making it clear enough how applicable those are for journalists. And we need to realize that here we have a lot of pediatricians. In the field, we hardly have any. And they need to be, whether it's CPAP, whether it's, how applicable is it for a basically trained? We accept physicians with only 2 years of training out of medical school. Most of us non-pediatricians find this a bit intimidating. So potentially a next step is to, how do you make this applicable and practicable by completely non-pediatricians who get scared when they see a very young baby?
Thanks a lot. I think this is, there are 2 different answers, I think. One is for KMC, where I think there is very low level of expertise needed, but you just have to be convinced.
If
Go
I
ahead.
can give a brief left-brained, right-brained answer. So this is the right-brained answer. The left brain is my big brain. I've got a small right brain. Actually, when you do the skin-to-skin, what happens is that the baby opens his or her eyes. And the very eye contact that the mother makes, even that I make, reassures me, makes me feel safe. It's the oxytocin circuitry that's working, and the oxytocin circuitry is the social hormone, it's also the healing hormone. It's the right-brained answer. When you can do this in a way that the eyes open, your mother will feel so good with her baby, no matter its size, that she will be very good at reassuring you that it'll be okay. Now, I can give you a 20-minute left-brain answer about what you also need to do.
Well, coming to pulmonary support for preterm babies, I think it's not easy. There are projects within MSF that provide CPAP treatment. My vast experience with N = 1 says that there are, and that is sort of one way, but I'm fully aware that in many of the most of the settings where MSF works, it may be impossible at the moment. However, we are discussing something like 30% of under 5 mortality. And we do put a lot of effort into other very much less diseases that kill very much less patients per year than that 30% that are preterm births all over the world. 17% of all children that die before age 5 die during their first 24 hours of life. And the majority of these are asphyxiated babies, meconium aspirated babies, but most of them are late preterms, very low birth weight babies. So I think it's worthwhile to think about it. The other thing is that I hope I stressed enough that I do put a lot of hope into high-flow nasal cannula for this group of babies, which is a very much lower tech than the CPAP. It should be possible for people to learn to administer it, and you get the flows. You just need to be able to fractionize oxygen.
Thank you. Just, I know you're the next one. I just would like to add on this to ask you to outline in 2 words, if possible, what are the minimum requirements that you need? Do you need to have an X-ray in case of pneumothorax? Do you need to be able to monitor the pH? You know, like, what are the minimum requirements apart from the training and the skills of your personnel? What is your opinion? And I'm not just saying that this is written in stone, your opinion, it's an opinion.
Thanks for that last comment. That is not written in stone, and you will not cite me, I hope. I would say you do not need the X-ray in the first place. I think the risk on pneumothorax is a bit exaggerated. There are actually people that argue that the correctly administered CPAP reduces the risk of air trapping and pneumothorax. So it's not a question of CPAP and X-rays, it's a question about preterm babies then and the X-rays. The minimum level, otherwise, of course, I like the full blood gases, I like all the equipment, but you can do very much with the saturation monitor. That is definitely necessary.
Yeah, that is, with any oxygen, I think that is an agreement. Yeah. No oxygen if we don't have good saturation monitoring, especially in premas. So sorry, I delayed your question.
Thank you, Mats and Nils, for very inspiring talks. I don't know if it's a left or right side of the brain question. I'm a neonatologist, but I think this is anthropology. Why are we separating the baby from the mother in so many of the cultures around the world? Where does this practice come from? Is there a rationale? And from your experience, is it very context-based? Is there a system of belief that we need to understand when we're working in these settings? Thank you.
Nils.
Thank you for your question. Actually, anthropologists have asked this question very directly as a primary outcome and done studies. And Lowe's of Britain have published 167 out of 168 cultures different untouched, unreached, isolated cultures do not separate. And the one that does is in a particular situation where there's often infanticide needed to be practiced because they're desert people. And therefore, actually, it's not our biology, it's not our life sciences theory, it's not our anthropology. It's a product of the last 100 years. There's a story about the invention of the incubator but it's a product of our Western civilization and its pervasive influence. And therefore, I made the appeal that we shouldn't be static about the culture, but that we should go back and ask a generation or two, your granny didn't do this. No, well, let's go back to her. So indeed, thank you, but it is our biology is no separation, never alone.
Thank you, because that was also a thing out of the cots. There's one question here, then one there, and then one over there. Just talk.
Okay, my name is Thomas Brunner, neonatologist in Stockholm.
No, don't talk. I think it's not working. Sorry, this young gentleman will help you.
Can I talk now?
Yes.
Thank you. Thomas Brunner, neonatologist in Stockholm. Working in low-income settings, I think you often confronted with questions on hygiene when you're bringing parents into the overcrowded neonatal units. Do you think there any risk in these high crowded units in a setting where you have tuberculosis and you're afraid of other diseases? Is there a risk of bringing parents to the ward, and how should you meet it? Should there be some minimal conditions regarding water supply, showers, toilets? How would you discuss on that? Both, or all three of you, please.
So I think specifically to MSF, you are where you are, and you accept what you have where you are. And the definition that I present for skin-to-skin contact is a biological one. Care does not change. Actually, if you weren't washing your hands, please change that and start washing them. We have no doubt that hygiene does have an impact. What we do know, if you narrow the question, and I ask it slightly differently, does skin-to-skin per se increase infections or cause problems? Here we do have some poor evidence. It does not increase or decrease infections. It makes them stay exactly the same. But severe infections are much less. The key, though, is that it's not in isolation. And I think what I would do pragmatically is to say that skin-to-skin contact comes with mother's milk. And I think if one has the microbiota principle of no separation and you get an early colonization, in fact, Maria Domingos Bello is doing such research now. The microbiota is protective, but it also comes with the synergy of maternal milk. And so I think the synergy of skin-to-skin contact and breastfeeding, I didn't mention it there, but I think we used other mother's milk quite freely where I was initially, and then we stopped that because of the HIV. So yes, there are other contextual things that come into play, and we should be sensible. But infection, skin-to-skin, does not increase or make it worse. There is a difference when you do sporadic, intermittent skin-to-skin and a lot of traffic to the kind of committed skin-to-skin environment where you're providing access and constant parental presence.
If I might just say, there's very many different kind of contexts. And if I think of our projects in South Sudan, for example, where what we did is we just limited the number of people who could visit and be with the baby. And the mother, of course, always has access to the baby, and the babies are in the same bed as the mother. And the entire issue is about hygiene in the ward in general. And it's not about masses of people coming in, because of course if you allow masses of people coming in, you have the issues that you were referring to. But I think there's a middle ground. But sorry.
Yes, I'm Ann Lindstrand. I wanted to pick up the thread of the capacities of neonatal care in the MSF missions, as you were saying before. because it's true we're not many pediatricians or pediatrically trained people who knows how to do all these complicated things. Since the last a few years back, all MSF volunteers going to the field get trained in a simulation training on neonatal resuscitation. And that also freaks out everyone who's not been trained before, but it can be done, and it can easily be done. And it really makes people awake, not pediatrician, not general, young doctors, nurses, whatever, to actually have an eye on what happens right after birth. And it's not complicated, and as you say, Mats, that's where you have the highest mortality in the first hours. And isn't that a way to go also? MSF Sweden has offered a long time trainer by trainer offices. I mean, you can come to Sweden. Thomas is there and you're always there, and you can come and see how it is done. It's building a tent and trying to make a simulation in real time of what you actually do right after birth.
And it's very good. I did it myself last spring before going on my first mission.
I was very intimidated.
And you taught me a lot.
In fact, this training what we do in MSF is we use the American Academy of Pediatrics approved training, Helping Babies Breathe. And this is freely available not only for people who go on mission, it's integrated in the neonatal training, and it is in every single field where there is neonatal care. The thing is, our job is to enhance it and to keep it alive. Because it's, as you said, it's not complicated, but if someone has never done it, they're afraid of doing it. And that's the main message.
Maybe I can say that Lisa Humphrey is leading a group also within MSF that is looking at the Helping Babies Breathe, and to try to expand it a little bit, because the ILCOR guidelines or the American Heart Guidelines, where are you, Lisa?
Up there.
Up there. They might be too complicated for the settings we are in, while Helping Babies Breathe do not go beyond simple breaths, and we need something in between. This is a comprehensive group constituted of the Master of Oxygen, Ola Didrik Saugstad, Lisa, myself, Charles-Christophe Röhr in the UK, and Morten Breindal. So we hope to have a proposal for a new algorithm rather soon.
Okay, so we have 3 more questions. Maybe 2 more. Well,
yeah, okay. I'm also involved in the immediate skin-to-skin research together with Nils, and I would just point out that we should not become too it's not a salvation skin-to-skin contact. You need to have the training for resuscitation. We need the technical equipment. We definitely need that. It is a challenge of implementing skin-to-skin immediately on these very low birth weight infants. It's dangerous. And so we have to have respect for training and technical equipment, but the place, you can replace the infant as soon as you're ready with your stabilization, transition assistance, resuscitation to the safest place. So I think we have to keep this in mind. Don't go home and think you can put skin to everyone immediately without some training, without some, especially as Nils mentioned, securing the airways. I think this session is perfect because it's talking about airways and skin to skin. It's really combined, good combination.
Thank you. Jenny? Oh, there was one other one, and then Jenny. Okay, so we do have 2 more questions.
Thank you.
Sorry.
Hello?
Yeah, go ahead.
Hello? Yes, it's working. It's a very quick one. It's related to postpartum depression. For the experience of kangaroo or skin-to-skin care, have you found that, or is it a challenge that you face, or do you offer it to all women, and have you found a challenge like that related to postpartum depression?
That's for you.
So I only know of 2 randomized controlled trials that have addressed this, one from Brazil and one from Canada. The Canadian one found a score of 7 in the control group and 4 in the intervention group at first antenatal visit, from 2 or 3 hours of early first day skin to skin. The Brazilian one found an equal effect size, but on a much, I can't remember, something like 100 mothers. So nobody's actually asked the question whether it's the primary outcome. It's kind of fiddling in there, and there's anecdotes. But purely in terms of our biology that I've presented and the role that dopamine, serotonin, and other hormones play in the reproduction, is good logic that skin-to-skin would have a protective effect.
Thank you. One last short question with a concise answer by whoever the question is asked to.
It's a short question to Nils. Where, in your opinion, is the optimal care environment for neonates in low resource settings with neonatal tetanus?
Neonatal tetanus?
Yes, which we have a lot.
I last saw neonatal tetanus personally way back. So what was your question? Last best place?
Where should those babies be best taken care of, those ones with neonatal tetanus?
I can't answer that. I saw a lot of neonatal tetanus before I started doing skin-to-skin. I never tried to combine them. I don't know the answer.
Yeah, thank you. Well, as you see, that's I'm sorry, but I was told to even stop before the last question. So thank you very much to Nils, to Mats, but also to all the questions that came, because I think this is just a start. And I just want to stress that one thing that we have learned is without nurses and midwives, we can't do anything. And I think this has come through. Organization of care is important. And skin-to-skin care is something that we all want to promote. However, there are quite a lot of challenges that we still have to face, and it's important to exchange on those, because space is one thing that we usually do not have in our hospitals, and that's where it usually starts in MSF settings, that we don't have space for that. Thank you very much.